Welcome, everyone. My name is Ted O'Connell. I'm one of the authors of Crush Step 1, the ultimate USMLE Step 1 review. This is the second edition of the book, and we're going through it chapter by chapter. This is part 9 of the Cardiology chapter. We're going to start by talking about rheumatic fever. Rheumatic fever occurs in about 3% of cases of untreated Group A streptococcus pharyngitis, strep throat. With the advent of antibiotic treatment, rheumatic fever has become rare in developed countries. Note, although post-streptococcal glomerulonephritis can occur after either a skin or pharynx infection with Group A streptococcus and cannot be prevented with antibiotics, only a pharyngeal infection with Group A streptococcus can cause rheumatic fever, and this can be prevented with antibiotics. Rheumatic fever is primarily a disease of childhood and adolescence because children more frequently have strep throat. These bacteria have a protein called M protein. When the immune system makes antibodies to the M protein, they can cross-react with proteins on the heart, leading to symptoms, a type 2 hypersensitivity reaction. The criteria for diagnosis are called the Jones criteria, and the mnemonic Jones can help you remember the main parts of this. J is for joints. This is classically described as a migratory arthritis that affects many joints but leaves no permanent damage. Most patients with rheumatic fever will have this symptom. O is for obvious, the heart. Rheumatic fever affects the heart, so it can damage the heart. This can range from endocarditis leading to valve damage and risk for future infective endocarditis, to myocarditis, an inflammation of the cardiac muscle itself, which can be fatal, to pericarditis. Rheumatic fever can thus easily become rheumatic heart disease with permanent damage to the heart. N is for nodules, subcutaneous nodules that are painless and firm that can appear, typically over bones or tendons. E is for erythema marginatum, an erythematous macular rash that spreads out, leaving a clearing in the middle. S is for Sydenham chorea, also known as St. Vitus dance. Chorea refers to involuntary abnormal movements from the Greek word dance. Sydenham chorea affects all limbs and can occur months after the initial infection. Now let's talk about infective endocarditis. Endocarditis is inflammation of the endocardium, usually involving the heart valves. Although there are non-infectious causes of endocarditis, such as Liebman-Sachs endocarditis from immune complex deposition in autoimmune diseases, such as systemic lupus erythematosus, or SLE, infective endocarditis is the most common endocarditis and the most highly tested on the USMLE Step 1. Infective endocarditis can be either acute or subacute, which is mostly dependent on the virulence of the organism causing the infection. Although damaged valves are easier for bacteria to latch onto because of irregularities in the surface, normal valves can be affected by virulent bacteria. Anytime there is a patient with fever and a heart murmur, consider endocarditis. Acute endocarditis is usually caused by Staphylococcus aureus, which can infect normal valves and aggressively destroy them. This is characterized by large vegetations, rapid onset, and patients who are very sick. IV drug use is the most common etiology. Unsterile injection technique seeds Staph aureus from the skin directly into the veins. Because the veins bring blood back to the right atrium, the tricuspid valve is the first valve the Staph aureus encounters and is the most commonly affected valve in acute infective endocarditis in IV drug users. Subacute endocarditis is usually caused by less virulent bacteria such as viridans group streptococci, which are found as normal oral flora in humans and routinely find their way into the bloodstream during toothbrushing and dentist visits. Because they are low virulence, they require damaged valves to attach and cause progressive and less dramatic symptoms compared with acute endocarditis. The most common valve affected in subacute infectious endocarditis is the mitral valve because it is often damaged by rheumatic fever, followed by the aortic valve. Other bacteria deserve mention, although they are much less common. Streptococcus bovis endocarditis can be found in patients with colorectal cancer. Staphylococcus epidermidis is implicated in endocarditis involving prosthetic valves because of their ability to generate a biofilm on the prosthesis. There is a group of bacteria that do not grow on standard bacterial cultures because they need a special environment to survive that is not provided by the culture medium, and they therefore cause endocarditis with negative cultures, the Haysick group of bacteria, Haemophilus, Aggregatibacter, Cardiobacterium, Eikenella, and Kingella. There are many symptoms and signs of endocarditis, although all may not be present in each patient. A common mnemonic for endocarditis is from Jane, because Janeway lesions can be present in endocarditis. F is for fever, the most common symptom, due to an immune response to infection of the valve. R is for Roth spots, due to immune complex deposition in the retina, causing inflammation and white exudate formation with hemorrhages, visible on fundoscopic examination. O is for Osler nodes, painful violaceous nodules on the extremities caused by immune complex deposition. M is for murmur, a new heart murmur due to infection and vegetation of the valve. J is for Janeway lesion, non-tender, small hemorrhagic lesions often found on the extremities can be differentiated from Osler nodes because Janeway lesions are non-tender. A is for anemia of chronic disease secondary to chronic inflammation. N is for nail bed splinter hemorrhages. These are linear reddish-brown lesions that look like splinters found under the nail bed. And E is for emboli. Small pieces of the vegetation on the valve can break off, leading to pulmonary emboli if the right heart is affected, or strokes and peripheral organ dysfunction if the left heart is affected. Diagnosis is by history and physical exam. Echocardiography to visualize the vegetation or valvular abnormality, and blood cultures to isolate the organism. Treatment is antibiotics, usually for at least a month. Now let's talk about pericardial disease. Pericarditis is the most common disease of the pericardium, characterized by inflammation that can be caused by a wide variety of agents. It can be either infectious, which is more common, or non-infectious. Infectious causes include Coxsackie B virus, which is the most common, as well as tuberculosis or other bacteria. Non-infectious causes include uremia secondary to renal failure, autoimmune causes such as SLE and Dressler syndrome, nearby inflammation such as from post-MI or myocarditis, as well as metastatic cancer. The diagnosis of pericarditis can be made both by history and physical exam, but also by an ECG. Findings. Classically, patients will have chest pain relieved by sitting forward. On cardiac auscultation, they may have a pericardial friction rub because the inflamed pericardium no longer provides a smooth surface for the heart to beat against. ECG. Because of diffuse inflammation, the ECG shows diffuse ST segment elevation and PR segment depression. The ST segment elevation can be differentiated from that of a STEMI because it encompasses the entire heart, whereas an MI affects only sections of the heart supplied by the occluded artery. Although pericarditis is often self-limited and benign, possible complications include pericardial effusion with possible cardiac tamponade, as well as constrictive pericarditis. Pericardial effusion. The inflammation can lead to fluid accumulation in the pericardial sac. Because the pericardium is fibrous and does not stretch easily, acute accumulation of fluid in the pericardium can be dangerous and lead to cardiac tamponade. Chronic fluid accumulation in the pericardium allows for stretching of the pericardium. Therefore, larger volumes can build up without causing tamponade. A hemorrhagic effusion is most likely due to tuberculous or malignant pericarditis. With a large effusion, electrical alternans can occur. The heart is essentially swinging in a large effusion and causes the recordings to alternate depending on whether the heart is moving toward or away from the chest wall. Constrictive pericarditis. The inflammation can lead to scarring, where the two pericardial layers adhere to each other and fill with fibrous tissue, preventing filling of the heart. Cardiac tamponade is a life-threatening emergency. The heart becomes compressed by fluid in the pericardium, preventing filling of the ventricles and subsequently decreased cardiac output. This can be secondary to an effusion or bleeding due to trauma, such as a knife through the heart, as well as by ventricular wall rupture or extension of an aortic dissection into the heart. Beck's triad is a constellation of three findings in tamponade: hypotension from decreased cardiac output, jugular venous distension from blood backing up into the veins because the heart cannot fill, and muffled heart sounds because the heart is being strangled with fluid. Pulsus paradoxus can also be present in tamponade and is an exaggeration of a normal physiologic response. During inspiration, the negative intrathoracic pressure increases venous return to the right heart, filling the right ventricle with more volume. This larger filling of the right ventricle causes the septum between the right and left ventricles to bow toward the left ventricle, reducing left ventricular filling and causing a small decrease in cardiac output and thus blood pressure. In cardiac tamponade, because there is so little room in the heart, this effect is exaggerated, and the blood pressure drops by more than 10 millimeters of mercury during inspiration, called pulsus paradoxus. Treatment of pericarditis involves treating the underlying cause when possible, such as dialysis and uremic pericarditis, as well as using anti-inflammatory medications to prevent the inflamed pericardium from developing an effusion or scarring. With tamponade, immediate pericardiocentesis, needle drainage of the fluid, is indicated. Vasculitides. Vasculitis refers to inflammation of the blood vessels, which can be classified as small vessel vasculitis, affecting small vessels such as capillaries, medium vessel vasculitis, affecting smaller muscular arteries, and large vessel vasculitis, affecting the large elastic arteries such as the aorta. And that's the end of this section. In the next, we'll start by talking about cardiac and vascular tumors.